tell me what you first did. Tell the jury, rather, what you first did in your job, as you saw it, to survey this course of treatment, and then subsequently, I suppose, examine Maya. Tell them how you went about it.
Right. So, they sent me a boatload of documents. Scary. That was scary. That was like documents like 5,000 pages. And but I don't review documents before the patient comes in. I need to make my own opinion first.
Why is that important?
It's important because I don't want my thinking to be biased by reading other people's reports.
Is there a problem in medicine with a diagnosis taking on a life of its own, otherwise known as a narrative?
Yes, it's a major problem. What happens is that one physician, maybe depending on his competency, incompetency, makes a diagnosis without any basis, and then that gets populated into the medical records, and then after that it's just passed on forever because no one wants to change that.
And so it takes quite a bit of gumption, for lack of a better term, to step in and change the narrative.
Objection to the leading, Your Honor.
Sustained.
What, if any, effort does it take to change the narrative?
It's almost impossible. I've had a few patients who have tried to do that, and it's extremely difficult.
But does that mean a doctor should just blindly follow a narrative, or should they give it an independent view, excluding a narrative?
So if it's a major diagnosis, and it affects, so if I'm seeing a patient, and let's say that I'm seeing the patient for pain in their left knee, and they also have asthma, I'm not going to worry too much about the asthma part. I might say, hey, do you have asthma? And they'll say, yes, I do. But I'm not going to go into great depths with it. My focus would be more on the knee part then.
So you saw Maya first before you reviewed all those records?
Yes, I tend to, the way I work is, I don't like to be biased, so I see the patient first, make my opinion, and then I go back and look at the medical records in detail, and then figure out where we are with it.
So I want to deviate a little bit from going through your findings, and I first want you to help us understand CRPS as you know it. Have you treated CRPS patients?
Oh yes, I have a lot.
Okay. Can you give the jury an idea of how many per year?
I actually did that calculation for this. Yes. So approximately 5 patients a week for 20 years, and the math came out to be about 125,000 patients in the last 20 years with CRPS.
My goodness. And have you yourself participated in any studies or surveys?
No, I haven't. You mean done research on it?
Yeah, or cooperated in providing patients for clinical evaluation, things like that.
No, I don't want to. I don't like to send my patients for clinical. They're already in so much pain and they're already suffering, and I don't do that.
Understood. So tell us now the signs and symptoms of CRPS that they can understand as we go through this and show photos that they should look for here.
So CRPS is one of the few pain conditions that you can literally see. I mean, if I say I have a headache, you can't see the headache. If I say I have knee pain, you can't see that. But CRPS is one of the conditions you can actually see. And the diagnosis of CRPS is based on very clear rules and regulations. There's a whole checkbox, and you have to check certain boxes. And when you check a certain number of boxes, then you come to the conclusion that the patient has CRPS. So for example, Am I?
Yeah, no, please, I'm asking you to go through if it's okay.
Right. For example, obviously the first one is that the patient has severe excruciating pain and there is no other explanation to it. Nothing else explains it. That's the number one. Number two, the rest are kind of optional, and you have to pick and choose which ones you see. So one of them is there a temperature difference? So if I have CRPS in the left leg, and so the temperature in my left leg might be hotter or colder as compared to the right leg. The next thing is you look at color change. Oftentimes the affected side is either dark red in color, even blue in color as compared to the right side. You look for swelling. In the initial phases, swelling is pretty obvious. Later on, you don't see it as much. So you look for swelling in these patients. You look for skin changes. The skin may sometimes become thin and shiny, or they may develop small, tiny lesions, almost like blisters that are painful. They can develop that. They even develop hair changes. Some patients actually grow more hair, and some patients have less hair. It can be in the same side or on the opposite side. You can see nail changes. Their nails start to kind of break off. They get brittle nails.
And what about asymmetry in muscle groups from right to left? Is that an
Right.
indication?
I was getting to that. So
Sorry.
the last one is muscle symptoms. So do they have what's called dystonia? Dystonia is a terrible condition. So I'm going to show you. Like, if I had dystonia in my left hand, it would be like a tight muscle, like the arm is taking a life of its own and it's cramping up. Or they may have tremor. So they may not have tremor when you don't do anything, but if you say touch them and then they start to have a tremor, they may have muscle weakness, they have muscle atrophy, the muscle starts to shrink. So there are many muscle symptoms that these patients can have.
I want to, if you could, and I think I wanted you to explain what really happens in CRPS, the central. I want you to explain what we know so far about CRPS,
Wait,
how
one
it
second.
starts. Yes.
I just have one other clarification on
Go ahead,
CRPS.
please.
When I say that these patients have pain, we're talking about the world's worst pain. I mean, this pain is worse than amputation pain. This pain is worse than childbirth pain. The gentlemen on the jury won't understand that, I'm sure. This pain is so bad, so bad. The worst part about this pain is that, if I stub my toe, it looks like the world is going to come to an end, okay? But I know that this is going to go away in a few minutes. But CRPS pain does not go away. It's there 24 hours, 7 days of the week, and it just stays on and on and on. And the worst part is that there's no known treatment to this. We try all sorts of things. Some work, some don't work. But this is such a this is often known as a suicide condition, because these patients, the pain is so bad, they can't sleep, they can't eat, they can't work. Their families don't believe them because you don't think like somebody. The general impression is, oh, you have pain, take a Tylenol and it'll get better. This is not Tylenol pain. This is your hand in a hot stove. That's exactly what they described as. In fact, patients describe it as if their hand is inside a hot fire stove, and and they can't take it out. That's the thing. So I just want to clarify that this is, when I say pain, it's not a small itty bitty pain in the joints.
And what is the McGill pain scale?
The McGill pain, so McGill University in Canada decided to see like, okay, where do pain conditions stand? So they interviewed a bunch of people and they said, all right, where in this scale would you put your pain? Like pain from labor or pain from amputation of a digit. And so they drew a scale, and that scale, CRPS was from the CRPS was way above anybody else. It was way above amputation pain, cancer pain, or even labor pain.
With your permission, Your Honor, I'd like to publish a photo of the McGill pain scale. Can you bring it up? The jury can see. Ta-da!
So
Miracles of technology.
what I'm seeing is what the jury is seeing.
Yeah, the jury sees that.
Okay, so if you go from the bottom, you can see, tension, headache, sprain, and so on. As you go up, then you see non-terminal cancer, chronic back pain, and as you keep going up, prepared childbirth is number 32, and then you keep going up, and then you come to amputation of a digit is 39, and then so forth, and then finally CRPS, often it was originally known as RSD, is rated as 46. So on a scale of 50, 0 to 50, CRPS is 46. Nothing is higher than that. It's such a terrible pain.
Now with this, can you tell us from your experience whether any of your patients have had, not parents, patients, but any of your patients have had difficulties going through a number of doctors before they're diagnosed?
Yes. So unfortunately, most doctors don't know about CRPS. They may have read about it and they must have blown it off as being an extremely rare condition. I don't need to bother with it. I'll probably never see it. But unfortunately, it is a very common condition. And they miss the diagnosis. They think it's an arthritic pain, or they think it's some sort of a muscle pain, and they get prescribed some of these itty-bitty pain medicines. And it was not an official study, but it was a very unofficial kind of an anecdotal article in a journal, and they said the average.
Hold on, Doc.
What's the legal basis? Sustained.
Well, just tell us what, without going into the details of any study, just tell us what the latest finding is.
Same objection, Your Honor.
What do you understand the latest, the standard, the knowledge of CRPS is, as you were about to relate?
You mean how many patients develop CRPS?
Well, that'd be interesting.
Okay, so, essentially patients go through a lot of physicians before somebody will say, you know what, I think this is CRPS, you should go and see the pain physician, and they might be able to better diagnose it.
Have you seen, or is it, the better question is it prevalent or not prevalent that when doctors cannot figure out this disease, they assign a somatic basis or a psychological basis?
Okay, so this is an interesting phenomenon. There is a difference between young women, especially, versus adults. Usually, young women, and CRPS is, by the way, very much more common in women than in men. When they present with it, it is often stamped as being psychological or anxiety or making it up or some sort of a psychiatric diagnosis. Like you really don't have pain, you're just seeking attention. In adults, it's a whole different situation. In adults, it is taken much more seriously. They are offered different treatments and different specialists who can then look at it more carefully. And that's the big.
Go ahead.
That's the big difference between younger patients and adults.
And so what is the effect on these children, younger patients, for having their pain denied by physicians repeatedly?
Well, put yourself in their shoes. Let's say you're a 12-year-old girl who develops this CRPS in her left leg from doing, acrobatics or something, or rollerblading or something. And then now you have this severe pain, and obviously the first thing your parents are going to do is, put something on it, give you some Motrin, Aleve and all that. Doesn't go away. And now it's becoming excruciating, and it's becoming red, hot, swollen, and you can't even wear clothes. So then your parents take you to the doctor, and then the doctor again has no clue what's going on, not sure what's going on. Eventually go from doctor to doctor because they go to an orthopedic, the orthopedic sends them to a neurosurgeon, the neurosurgeon sends them to a physiatrist, and it continues the cycle, and eventually they'll get to one person, and that one person will say, I know this condition, it's CRPS, and then they go on to, getting the treatment that they need.
So now once, what I'd like to go through now, if we could, and for this, I don't think counsel has an objection to the actual the pictures. That was not part of your objection. The glial cell picture.
It's only an objection to the pure demonstrative disorders.
All right. So on this, let's go to 12 if we can. Now, coming up here is something I think you provided for us to. It's an incredibly sophisticated artistry, but
Oh, that. It should be in the Smithsonian, I can tell you that. Are you seeing it?
yeah, there, just a second. He's getting it. I tend to jump around a lot, and so.
Right, I apologize, but that's my drawing, okay? But that's how I think, okay? When you have only one brain cell, that's how you think. So, so I just want to, before we get into this picture, I just want to explain to you what happens in CRPS. Like, okay, we got this pain, but what is going on? So, the brain is not a bunch of nerves. So if you cut open, well, my brain you'll see only one, but if you open Attorney Whitney's brain, you'll see a ton of nerves in there. But that's not what, it's only 20% of your brain is made up of nerve fibers. The electrical wires in your brain are only 20%. The rest of it is packing material. And that packing material is known as glia, which means glue. So in the old days, the thinking was that, there are these nerve wires in the brain, and to support it, you would put some packing material in there. And that was the idea, that there's glial cells, and they had no other function. But now we know that they have a lot more function. And besides CRPS, they're also implicated in Alzheimer's disease and dementia and other conditions. But in any case,
Let's show the next one.
Well-
The 13 here. Another beautiful sketch you've done for us.
so what happens is, this one I need to explain. If I take a pen and I stick it in my finger, a signal goes up into my brain, up my arm, into my spinal cord, into my brain. And my brain then reads it as pain, and I yell out, pull the pen out, I rub it, it feels better, everybody goes back to their business. But if I take a pen and I keep sticking it into my finger again and again and again and again for 24 hours a day, then there's a barrage of pain signals that are going to my brain, and there's a barrage of pain signals coming down. This traffic of pain signals activates the glial cells. These glial cells get upset, they get angry. And when they get angry, we can
Yeah, let's show
Go to the
14.
next slide.
Next page.
When they get angry, they release chemicals. These are called chemical inflammatory mediators, which means that they produce chemicals that cause the nerves. Because remember, these glial cells are around the nerves. These glial cells then, when they get angry or when they get inflamed, they then release chemicals that cause the nerves to get inflamed.
Let's go with 15. Okay.
So now the nerve is inflamed. And this is the basic mechanism by which a lot of chronic pain can be explained, but this is the basic mechanism behind which CRPS is explained. So what I'm trying to say is that CRPS pain, so if I have CRPS in my left leg, it doesn't live in my left leg, it lives in my brain. So you could essentially cut my left leg off, I would still feel the pain because the glial cells in my brain are still activated. Eventually, if you cut off my leg, eventually the glial cells are going to say, oh, we're getting no more signals, and then they calm down, but that's a different story. So the treatment for these glial cells to calm down is, all treatments that we do are to make these glial cells calm down so that they are not as angry.
Do we know why the glial cells get angry yet?
We're not 100% sure why they get inflamed, but one of the theories is pain that comes on from CRPS. The repetitive pain signals going to the brain cause these glial cells to get inflamed.
And can this process, the CRPS glial cell aggravation, start in some patients from an emotional event?
So once these glial cells are inflamed and you're in the process of treating them and they're starting to calm down, like not all of them calm down at the same time. Some calm down and some don't, and say 20% will calm down first. But if there's a triggering event like, let's say, emotional stress or physical stress, then these glial cells go back to getting inflamed again.
And so does that happen every time, or is that, again, kind of a hit or miss on whether it's going to happen?
That's a difficult question to answer because there's a lot we don't know why this is happening. So it's, depending on the stress, okay, I have an exam coming up, the glial cells are probably not going to get activated. But if somebody came and punched me in the nose, then I guess the glial cells would get activated.
And through the course of this, and we'll get back to the examination in a moment, but through the course of this, have you had the opportunity to review the Johns Hopkins records pertinent to this case?
Yes.
And can you explain to the jury in terms of this, some of the cells being activated, some of the cells being not, the problem with interrupting a treatment process?
So I have to go, in order for me to explain that, I have to go a bit outside the Johns Hopkins treatment paradigm.
Go ahead.
So in this case, she was getting her treatments, okay. She was seeing doctors, the doctors were giving her drugs, and she was starting to, there's a whole algorithm. It's not just simply giving ketamine or some one drug and magically everything disappears. So she was slowly starting to get better and much more active. And then what happened was at the Johns Hopkins, all of this was suddenly stopped. And when it stopped midway. It stopped at a point where she was improving, everything was stopped, and the glial activation came back, her pain came back, and plus the stress, the emotional and the physical stress. Remember, one of the things I told you about CRPS was that this is pain to touch. So it's not as simple. Even the slightest touch causes pain. But the problem is that if I have CRPS in this hand, and if I touch it lightly, the whole hand hurts. and it continues to hurt for weeks. And what was happening at the hospital was everybody walking by would touch her to, I'm not sure why, to test her, to examine her, for whatever reason. Various people would touch her again and again at different places, and each time they did that, it was triggering the pain again. And remember the barrage of pain signals going up to the brain that would cause the glial cells to get inflamed? That would keep repeating again and again.
Is that one of the reasons why well, let me ask you, do you have an opinion based upon your background, training, and experience, and from your examination of Maya and your review of the records in this case, as to whether the treatment she received at Johns Hopkins All Children's Hospital in October, November, December of 2016, and then into January of 2017, whether that permanently aggravated Maya's CRPS?
Is that the time when she was sequestered in the hospital?
Correct.
Yes, that did.